Okay, hello everybody. My name is Stephan. I'm pediatric immunologist working at the CCI in Freiburg, Germany. I welcome you to this ESID Grand Rounds webinar on JAK inhibitors in inborn errors of immunity of the JAK-STAT pathway. You can see the participants here, and they will briefly introduce themselves with their talks. Just a few words of introduction. See. Yeah, there we go. So today it's all about targeted therapies, and I think this is really an exciting new chapter in the treatment of inborn errors of immunity, where for many years we've had immunoglobulins, antimicrobial prophylaxis, steroids, immunosuppression, and hematopoietic stem cell therapy or gene therapy. But this is opening new possibilities, and it invites us to rethink also our therapeutic strategies and algorithms. But with these new targeted therapies, of course, there are not only opportunities, but there are a lot of challenges. So which drug do we use, actually, if we have a choice, as for example in JAK inhibitors? Which is the appropriate dosage for different age groups? Do we have enough information about pharmacokinetics? How do we achieve balanced pathway attenuation? And how do we read out whether we achieve this? How about side effects? Side effects on target, so meaning for the JAK inhibitors, for example, side effects that arise by inhibiting this pathway. And how about off-target effects with the doses that we are using? One of the key questions that comes up in these autoimmune lymphoproliferative diseases is the issue of malignancy. So do we put patients at risk, or do we offer protection by interfering with these pathways? And then, of course, another question is, do we have this now as a bridge to transplant, or do we offer this as a treatment for life? And I think many of these questions cannot be answered by single studies, but we need the comprehensive experience of many people using the drugs to really define their appropriate place in therapy. Now, another aspect that I want to briefly mention is JAK inhibitor therapy really targeted? It's a JAK inhibitor, so for JAK1 gain of function, I think it makes sense. But then we have STAT gain of function diseases, SOX loss of function, USP disease. And in recently, something's wrong here. Okay, now. And there have been many diseases, new diseases discovered, and they all end with a sentence, well, and we also have a targeted therapy. And in 90% of the cases, it's a JAK inhibitor. So how targeted are we really working in other diseases like Aicardi-Gouttière, SABI, Candle, A20, COPA, polymerase A? Is this really still targeted therapy, or are we working close to the target, but a little bit on the side? And does what we learn about JAK inhibitors in JAK gain of function really make sense for all of these other diseases? Now, what we will talk about today is not the whole range of diseases, but we will focus on JAK-STAT diseases. And Bénédicte will give an introduction. This is just an overview of the pathway, and I think she will go further into it. But you can see that we are talking about these drugs at several levels. So at the level of the biochemistry, of the biological impact of these drugs on signaling pathways. We are talking about immune cell behavior, and we are talking, of course, about clinical manifestations. And I think all of these issues need to be understood to really give the drugs their appropriate place. So with these few remarks, I would like to start, and here's again an overview of the program, and I would like to introduce Bénédicte with her first talk. Bénédicte, please.
Thank you very much, Stephan. So I'm Bénédicte Neven. I'm a pediatric immunologist in Necker Hospital in Paris, and it's a great pleasure to be here today. And with a few minutes, I will try to introduce you to this pathway and also to the gain of function diseases related to this pathway. First of all, if it's working. This pathway allows a very quick transmission of signals from the different receptors, type 1, type 2 receptors that are devoided from enzymatic activity. And this message will be transduced to the nucleus thanks to the association of two JAK molecule and two STAT molecules. So we have 4 different JAK and 7 different STAT, and the specificity of the homo or heterodimers will give the specificity of the signal transduction. There are a lot of cytokines, interleukins, hormone, and growth factors that transduce through this pathway with 57 different molecules. It's a very important pathway that needs to be tightly regulated thanks to the SOX molecules and the PTP. This is a very critical pathway for the immune system, for the lymphopoiesis through the type IL-2 family receptor cytokines. It's also important for hematopoiesis, for the homeostasis of the immune system and tolerance, for the fitness of the immune response, for the effector CD4 T cells differentiation, inflammation and control of inflammation, but also for innate antiviral responses. So it's a very important pathway for our immune system. We know from studying in bone errors of immunity that some of these pathways are non-redundant, because if you have loss of function mutation in some of these molecules, you have a infectious susceptibility like JAK1, TYK2 molecules that give rise to microbacterial and viral susceptibility, and other phenotype observed in STAT1 or STAT2, STAT3 or STAT5B loss of function mutation. But we also have gain of function mutation that is the topic of today, with various clinical phenotype related to the gain of function mutation of these important molecules. And there are a first phenotype that is mainly lymphoproliferation and autoimmunity in STAT1, STAT3 gain of function. Then there are the more allergy and hypereosinophilia phenotype in JAK1, STAT5B, and STAT6 gain of function. And the last one, which is STAT2 gain of function, that will give rise to more autoinflammation and interferonopathy-like phenotype. So the first disease, I will go quick through it because I think most of you already know very well the STAT1 gain of function clinical phenotype. First of all, there is infectious manifestation with chronic mucocutaneous candidiasis that are almost found in all patients and usually occur quite early in life. Then there are the bacterial infection related to a defect of antibody responses, and the viral infection, mainly skin viral infection in many patients. They can also have less frequent manifestations, such as microbacterial infection or invasive fungal infection. Autoimmunity is frequent in almost half of the patient. IBD-like phenotype is also frequent with apoptosis, which is quite important and frequent for the patient. And there are extra hematopoietic manifestations such as aneurysm, mainly cerebral aneurysm, and in some cases malignant tumors and squamous cell carcinoma can occurs in these patients, probably resulting from chronic inflammation. We know from 2015 that JAK inhibitors can be interesting drugs for this patient, with many case reports mainly showing some interest for these drugs and some benefits, but also some limitation in some patients with severe infection that did not respond to JAK inhibitors. For the STAT3 gain of function, again, I think you are quite well aware of the phenotype with chronic lymphoproliferation present in almost all patients, 80% of them. Autoimmunity is also a frequent phenotype with autoimmune cytopenia or more targeted autoimmunity like endocrinopathies. There are also lung phenotype, which is important in this STAT3 gain of function. And this lung disease could be interstitial lung disease or fibrosis. And this patient can also have frequent enteropathy. And because all of these manifestations can vary in severity or frequency, this patient can mimic ALPS phenotype or IPEX phenotype. And this is a frequent way of diagnosing these patients. Again, the interest of JAK inhibitors in this disease came from a few reports showing the interest of these drugs in the IBD-like phenotype, but also in the interstitial lung disease. And Carsten will go more in details regarding these benefits. Then in the JAK-STAT gain of function pathway, there is a more recent clinical phenotype that is now appearing, and this is the allergy related to the JAK1 gain of function, STAT6 or STAT5b gain of function. These patients have a very similar presentation, but there are very, very few patients published so far. And these patients have hyper-eosinophilia, dermatitis, asthma, and liver or gut infiltration with eosinophils. Again, the interest of JAK inhibitors was shown in these very few case reports with nice and good control of symptoms and hyper-eosinophils by ruxolitinib. Again, for STAT5b gain of function, these are case reports. Patients have early onset skin disease with a variable phenotype, dermatitis or urticaria. Alopecia were also described. Again, gut infiltration with eosinophils is frequent, with food allergy, also lung disease, asthma, failure to thrive, and hepatosplenomegaly was also described in one patient. Hypereosinophilia and hyperlymphocytosis are key features in this patient, again, with preliminary results in 2 patients showing the interest of the ruxolitinib in this patient to control or improve clinical manifestation and hypereosinophilia. STAT6 gain of function are also reported recently with few patients again showing an increase STAT6 signaling through IL-4 and IL-13 at baseline and after cytokine stimulation. And again, patients suffered from food allergy, asthma, skin disease, and eosinophils infiltration in the gut. So I think this is an important phenotype that will probably increase, or more patients will probably be diagnosed in the future. And this is very interesting because JAK inhibitors can maybe be interesting drugs for these patients. Then there are one important phenotype, the STAT2 gain of function patient, which is more interphenopathy-like phenotype with a very high inflammation, intracranial calcification, increased ISG. This is a biallelic disease, which while the others were autosomic dominant, this is an autosomic recessive disease, and it's related to the defect of USP18 which is normally regulate the type 1 interferon signaling, and the interaction between USP18 and JAK1 are disrupt because of the STAT2 mutation. There are very few reports. We are aware of 9 patients. It's a severe disease because 7 patients died. And there is also an interesting phenotype that we don't really understand, which is pulmonary alveolar proteinosis that we observed in 2 cases, and that was also reported in 1 patient. So a broad clinical phenotype related to this gain of function mutation in the different partners of this pathway, and many interesting drugs to target this pathway, with several JAK inhibitors under the market, with variable specificity of these drugs. The first one that reached the market was tofacitinib, JAK1, JAK3 molecule that inhibit the JAK1 and JAK3, licensed in rheumatologic disease, GIA in children, and IBD. It's the only drug with a license in children. Ruxolitinib and baricitinib are 2 JAK1, JAK2 inhibitors. Ruxolitinib was licensed for malignant disease and GVHD, while baricitinib reached the market for rheumatologic disease. Then there are a few JAK1 more specific inhibitors, the upadacitinib, the filgotinib, and the albrocitinib, that both reached the market, the European market, in the last 12 months. For rheumatologic or digestive diseases. We have to be aware that none of these drugs have been licensed for the drug we are targeting. And as Stephan summarized, there are many questions regarding the application of these drugs in the disease we are treating, which JAK inhibit, which dose. We have to be aware that the highest the dose we use, the less specific is the drug. If we increase the dose, the inhibition is broader and can target the different JAK and TYK2 molecules. And of course, there are many questions between the balance between the benefice and the risk in the long term. We have to keep in mind that these drugs have side effects, and Paul and Marie-Louise will face this problem with the risk of infection, mainly related to the type 1, type 2, and type 3 interferon inhibition. Also some hematologic side effects, and also side effects that are more concerned for children, like growth, because we know that growth hormone signals through JAK2, and also weight gain can be problematic in some patients because leptin also transduced through JAK2. Because of all these questions, we try to give some answers, and thanks to Carsten and Marco and Peter, we try to set up European retrospective studies collecting the experience from all over Europe, trying to give some answers, and I'm sure Marco and Carsten will give a very good overview of these ongoing studies. So, giving this, I really thank you for your attention.
Yes, thanks, Bénédicte, for this first introduction into the topic. And I think we will directly jump into the next talk given by Marco. Maybe I can just point out again that please put your questions into the Q&A section while the presentations are ongoing. We will have a common Q&A session after all the talks. So Marco, please.
My name is Marco Fischer. I'm a clinical fellow at the Children's Hospital in Zurich and Basel as in pediatric immunology and allergology. I will present today two cases of two patients I encountered during my time in Freiburg to illustrate the benefit of JAK inhibitors. The first patient is a 9-year-old girl, who was referred due to infection susceptibility and immune dysregulation. She had recurrent pneumonia and bronchopulmonal infections. She already developed on a young age, with 4 years of age, bronchiectasis. She had chronic mucocutaneous candidiasis, especially oral and vaginal candidiasis. In terms of her immune dysregulation, she presented with a recurrent of those mucocutaneous lesions and diabetes mellitus type 1, colitis, and failure to thrive. Her family history, both her parents are healthy and non-consanguineous, and she doesn't have any siblings. Her current medication were at the time insulin and prophylaxis with azithromycin and fluconazole, subcutaneous immunoglobulins, Salofalk, and inhalation therapy. Her immunological phenotype, she had a normal proliferation. In terms of her Th17 cells, as you can see here, we weren't able to detect IL-17 positive CD4 T cells upon activation, and her STAT1 phosphorylation, as you can see here in the dark line, phosphorylation was increased in comparison to the control. The B panel showed an impaired B cell differentiation with reduced class-switch memory B cells, and she had normal IgGs, but IgG2 and IgG4 were decreased. In the genetic test, we could detect the heterozygous STAT1 gain-of-function mutation exon 11. We decided to treat her with ruxolitinib as an off-label targeted treatment due to her infection susceptibility, which was treatment resistant, and her immune dysregulation. I will show the results of this treatment at the end of my talk. I will move now to the second patient, which was referred 11-month-old boy, who was referred due to the neonatal onset diabetes with 3 months of age with an increase in insulin demand. As you can see here, this was prior to the referral. He had increasing insulin demand. In addition to this, he also showed inguinal and abdominal lymphoproliferation, recurrent panicolitis, and lipodystrophy at the insulin injection site. Family history was similar to the first patient. Both parents were healthy and non-consanguineous, and no siblings. His current medication was on metformin and insulin. The immunological phenotype was without relevant finding, showing a moderate T-cell lymphocytosis with normal expression of the activation markers. The regulatory T cell, as you can see here, were slightly decreased in the patient in comparison to the control. The B cell numbers were normal, and the differentiation of the B cells were normal as well. In the genetics, we could detect a heterozygous STAT3 gain-of-function mutation on exon 11. And we decided as well to treat this patient with off-label targeted treatment with ruxolitinib due to his lymphoproliferative and inflammatory manifestation. Here you can see the response of the treatment for the first patient. The first patient was treated in total so far of 38 months of treatment. And we can see that the CMC was we saw a complete response, the CMC of the inflammatory bowel disease and of those mucocutaneous lesions. In the bronchiectasis were stable, and no effect on the diabetes mellitus, and as well a partial response on the failure to thrive. The response of the second patient, STAT3 gain of function, was as well treated for 2.5 years in total. The The lymphoproliferation showed a complete response. Inflammatory skin disease showed as well a complete response. For the diabetes mellitus, you can see here as well in a nice publication of my colleague Oliver Wegehaupt, nicely shown that we saw an increase prior to the start of the treatment. And then with the ruxolitinib treatment at the beginning in combination with metformin, and a decrease as well in the insulin demand to a normal insulin demand, which is comparable with other diabetes patients. In addition, we saw as well that the lipodystrophy was partially responding. So the JAK inhibitor ruxolitinib seems to be an effective treatment in these two patients. However, STAT1 and STAT3 gain of function are heterogeneous diseases with various disease manifestation. And the previously published case series involved only limited number of patients. And with this, I would like to hand over to Carsten.
Yes, thank you, Marco. And with no further delay, Carsten, please.
Yes, thank you very much. So my name is Carsten Speckmann. I'm a pediatric immunologist at the University Medical Center in Freiburg, and I will update you on a retrospective study that we carried out under the umbrella of ESID and EBMT in Bone Marrow Working Party, where we wanted to understand the current use of these substances in patients with inborn errors of JAK-STAT pathways. So this has really been the question: what is the current treatment practice? And we carried this study out as a retrospective cohort study. We recruited patients from November 21 until last summer. Inclusion criteria were quite basic. Patient need to have a confirmed genetic diagnosis of a JAK-STAT inborn error and should have been on a JAK inhibitor for a minimum of 3 months. So looking in the demographical data, recruitment is completed. We recruited overall a cohort of 70 patients from 32 primarily European centers. And what I think is unique about this cohort is that we have a large pediatric population, and 14% of our patients have been even younger than 5 years. The majority of patients, 64, had gain of function variants in STAT1 and 30% in STAT3, and there were a few other inborn errors of this pathway. So what JAK inhibitors are usually used for these diseases? That doesn't necessarily mean that these are the best JAK inhibitors to be used. It's just what we are currently doing at our centers. This is what we want to understand. So there have been 72 treatment observations. The majority received ruxolitinib, followed by tofacitinib and baricitinib, and there were 2 patients who were switched from ruxo to bari. Now, ruxo is the most frequently used drug, and so you see here what are we doing regarding dose. You see there's a high variability. However, as a monotherapy and as a start, most are using this. Also, what we are doing, sort of mid-range between 50 and 30, and you must consider that if you look into these lower dose or higher dose patients, that of course other effects like co-medication or adjustment to clinical response play important roles in these lower or higher dose patients. Dosing is usually done twice per day for ruxolitinib. As for other indications, there is 1 patient who received a single dose, and there's increasing numbers, and we also tend to do this to give 3 doses, in particular in younger children who seem to tend to faster metabolize these substances. Often these decisions were based on PK observation. So Bénédicte already gave us a very nice overview on the clinical manifestation of these diseases, and what you see here is the manifestation in our cohort. So very similar picture of a heterogeneous, very intense immune dysregulatory phenotype. In red, you see the major disease manifestation in our patients. So how did these respond to a treatment? This is a very global assessment. First of all, looking into general well-being, 80% of patients were reported to have significant improvement of their general well-being. This has also been assessed in more detail by Konofsky index and is currently still under evaluation, which is also true for these other items that we investigate. But generally, we see a very good response, either complete remission in dark green or partial remission in light green for the most frequent manifestation: aphthous mucocutaneous lesion, CMC, inflammatory bowel disease, failure to thrive, a bit less responsive, and bronchiectasis. Difficult to assess, but these here were patients who received recurrent CT scans. So a majority of patients were at least reported to have stable disease and documented to have improvement to the previous clinical course. So here's the same cartoon for the STAT 3 patient in our cohort. In red, again, the main clinical manifestation, and here the treatment responses. So very similar picture. Again, doctors reported a marked improvement of general well-being of their patient being on this drug, and we see very good response rate to the most frequent clinical manifestations: lymphadenopathy, splenomegaly, inflammatory bowel disease, failure to thrive, and interstitial lung disease. What you also see, however, is that already looking into the STAT 3 patient, that this patient subgroup is already much smaller. So certainly difficult to assess in terms of significance in this effects, and also there are a bit more non-responders. These are global assessments. Marco showed you a chart of particular patient, and what also should be mentioned is that patient may respond differently. So there may be patient very well responding with improvement of lymphadenopathy, but maybe non-response of other clinical manifestations. So what has been the effect on immunosuppressive co-medication, shown here for the STAT 1 patient? There has been a reduction of concomitant steroid use, as well as other immunosuppressant. And this list of previously additionally used immunosuppressant is quite long, of course, often very distinct depending on the clinical manifestation, like vedolizumab being used in a patient with inflammatory bowel disease. In STAT 3, this is even more distinct. You see a very marked reduction of additional steroid use when the patient were on a JAK inhibitor, and also the sparing effect of other immunosuppressant was quite significant in this smaller group of patients. How about the effects on antimicrobial prophylactic co-medication? This has actually been difficult to assess. Yes, we see that there is a reduction, for example, in the co-medication of antifungal drugs in STAT 1, but these observations are certain difficult to interpret just because of highly variable local center policy. So there are centers who will always continue to have patients on antimicrobial prophylaxis while being on a JAK inhibitor, while others try to really observe the effects of the JAK inhibitor itself. This is even more pronounced in the patient with STAT 3, where there's even an increase of prophylactic co-medication like antiviral and Cotrim prophylaxis. Also because these patients probably tend to receive a bit higher doses to control their clinical symptoms. All of this is preliminary and needs further evaluation, which is currently ongoing. We look into the genotype of our study, and you see that we really see a mutation across the entire genes, and we did not see genotype-phenotype correlation, neither to the clinical phenotype in our cohort nor to the different treatment responses. How about adverse events? We will hear more about this in the next talks, but just very briefly for this specific cohort, 40% of doctors reported AEs. Overall, however, they were despite being common, often mild and transient. We saw in particular viral reactivation, so CMV, EBV viremia, which often resolved by itself after decreasing the JAK inhibitor. Pathological weight gain has been a significant issue in adolescent patients and also led to cessation of treatment. Neurological symptoms were subtle, like vertigo, nausea, and importantly, I think, very severe grade 3-4 organ toxicity were very rare and just an individual patient observed. So treatment was also stopped because of an AAE only in 4 out of 28 patients. 2 patients deceased who have been previously treated with a JAK inhibitor. However, there seems to be no correlation to the previous treatment, at least it's not obvious. What has been the reason when the dosing was modified? In the majority, 68% of decision, this was based on clinical judgment. So, for example, insufficient clinical response, or in those few patients I mentioned due to an AE. Molecular studies like looking into normalization of STAT phosphorylation or performing pharmacokinetics is currently just done in very few patients, although I think in particular assessing pharmacokinetics, in particular in young children, can be very helpful to guide clinical decision making. What were reasons to stop the JAK inhibitor? The most patients were JAK inhibitor were stopped. 11 underwent a secondary transplant and received the drug as bridging therapy. As mentioned, a few patients because of an AE, 3 patients because of an insufficient treatment response. There was 1 patient switched to another JAK inhibitor and then had a response, and 1 patient's clinical phenotype improved so that the previous indication resolved. There have been 11 patients transplanted in our cohort, 10 where we have detailed clinical data. The indication for HSCT has been multisystemic immune dysregulation or infection susceptibility, or a combination of both. Among these 10 patients, 7 had a gain of function variant in STAT1, 1 loss of function, and 2 STAT3 gain of function. Age range had between 1 and 18 with a mean of 9 years. Conditioning was half reduced intensity for myeloablative. All patients received serotherapy with a predominant use of Campath. Donor has been primarily matched, 1 family, 7 unrelated matched, 2 9 out of 10 mismatch, and the graft source has been primarily PBSC. And as I mentioned, all of these patients have been on ruxolitinib prior to transplantation. How was ruxolitinib withdrawn? The majority, 9 patients, had an abrupt stop of the drug with the beginning of conditioning. In 1 patient, the drug was gradually weaned until day 0. Overall, withdrawal was well tolerated. Under chemotherapy, there were no evidence for a critical withdrawal syndrome. 3 patients had a JAK inhibitor reintroduced. 1 patient because of a suspected, if then a moderate withdrawal syndrome with hypotension and body aches starting from day -6. Quickly resolving, and the JAK inhibitor was carried out until 4 weeks after transplant. 1 patient received JAK inhibitor treatment for acute GVHD, and 1 received prophylactic reintroduction because of a significant mixed chimerism. Looking into treatment observation, engraftment was complete in 7 patients. 1 required a second procedure, and 2 it has been partial, but with overall high total chimerism and good clinical control. There have been 2 graft failures, 1 primary in a patient who received a PBSC graft from a 9 out of 10 donor after myeloablative conditioning. This patient was successfully retransplanted in a haplo setting, and there has been a secondary graft failure in a patient who received a 10 out of 10 PBSC graft after a RIC regimen, and this patient deceased later due to an encephalitis. So overall, the outcome for such a critical ill cohort of patients, I would say surprisingly well. 9 out of 10 patients alive, several patients with significant follow-up time, and this 1 mentioned death. The disease status at last follow-up was judged to be cured in 50% of patients, improved in 40. Those 4 patients had moderate post-HSCT sequelae, 1 patient with controlled epilepsy, 1 patient with controlled lung disease, 1 patient remained IVIG dependent, and 1 patient mixed chimerism, but no obvious active disease manifestations. So in summary and outlook, I think our study supports that JAK inhibitors seem to be an effective and relatively safe treatment for these conditions. Drug dosing and monitoring varies considerably between centers, and the decisions are currently rarely based on PK. The outcome in a small series of patients undergoing HSCT with previous JAK inhibitor bridging therapy looks promising. Further analysis of our data is currently ongoing, and we hope that this can then also be helpful to launch a consensus discussion in the future, which I think would be very helpful. So overall, JAK inhibitors are efficient for treating these conditions, and I think there's sufficient evidence to push this further and to evaluate these drugs in randomized controlled trials to address more of the questions that Bénédicte has mentioned before. With this, I'd like to close my talk and like to thank in particular all the colleagues who helped to gather this data that I just presented to you, and my colleagues who helped me to coordinate this study in Sevilla and Paris. Thank you very much for your attention.
Okay, thank you, Carsten, for this important contribution. And we move on with Jerome, who is taking control of his own slides, I think.
Okay, so is it okay?
Yes.
Yeah, okay, so good morning, everyone. My name is Jerome Hadjadj. I'm a physician in Paris, and I'm going to talk today about immune dysregulation associated with SOX1 haploinsufficiency, so a new genetic defect in the field of the JAK-STAT pathway monogenic diseases. So I'm going to start with 2 clinical cases. So the first one is a woman from Danish origin. Interestingly, she had in her family autoimmune hepatitis in her father and 1 brother, and she was diagnosed with CVID at 28 years old with many bacterial infections, pneumonia, sinusitis. She presented 8 years before ITP treated by splenectomy. She had also psoriasis and skin lesions that you can see there, whose the biopsy showed granulomatosis. She had alopecia. She had also severe autoimmune hepatitis and benign lymphoproliferation with polyadenopathy. She had hypogammaglobulinemia, low switch memory B cell, and high CD21 low B cell. She was treated by IVIG substitution, steroid and azathioprine, and she presented many viral infections. And so we studied this patient by whole exome sequencing, and we identified SOX1 heterozygous mutation. The second case is a patient from 15 years old, a boy from non-consanguineous family from Madagascar. He presented with severe ITP with a recurrent epistaxis. He also had autoimmune neutropenia, so even syndrome with episodes of staphylococcal infections. He did not have other autoimmune manifestation or infection or lymphoproliferation and so on, and no biological sign of lupus or ALPS. He was quite well controlled under IVIG for the ITP, TPO agonist receptor with romiplostin and GCSF 1 injection per week. And we also studied this patient by whole exome sequencing, and we identify a SOX1 heterozygous mutation, a missense mutation. So, you well know the JAK-STAT pathway. Just to let you know that SOX1 is one of the main regulators of this pathway. He can directly inhibit the JAK kinase activity of the JAK protein and block the STAT binding to the site, to the receptor site. And SOX1 belongs to a family of 8 proteins, and it can directly inhibit and regulate the activation of the interferon gamma, interferon alpha pathways, the IL-2 families, and the IL-4. It will be important in the next of the talk. So we identified 5 families in collaboration with the team of Stephan L. You can see in gray that the penetrance is incomplete with some healthy carrier. The dominant, the inheritance is dominant, and so we identify 10 patients among 5 families. And in the same time, there was 2 other papers reporting 4 families, and so far there is 17 patients reporting among 9 families. The mutations can be inherited or de novo mutations, and there is a quite variable type of manifestation of mutations with 7 frameshift mutations, 7 missense, 2 nonsense, and 1 big chromosomal deletion was reported just recently in JOSI. As you can see, you will see the clinical manifestation are broad. So the median age at the first symptoms at 7 years old, but you can see that in one patient, the symptoms started at 44 years old. The clinical manifestations are mainly autoimmunity with mainly autoimmune cytopenia, but also organ-specific autoimmunity with thyroiditis, vitiligo, autoimmune hepatitis. There is also lupus. You can see here a pediatric lupus in one patient, and here psoriasis. There is lymphoproliferation, hepatosplenomegaly, adenopathy, organ infiltration, and one patient developed an Hodgkin lymphoma. Infections are not the main manifestation of the disease, but still there is in some patients recurrent bacterial infections, and some patients can present it with atopia. And all these patients were treated by multiple lines of non-specific immunosuppressive drugs with a lot of infection due to this treatment. In some new papers, other phenotypes were reported. Here, a patient with an hyper-IgE syndrome-like with empyema, severe atopia, and autoimmunity. Here, again, as the first patient, a CVID-like phenotype with hypogamma, alopecia, and lymphoproliferation among the lung. And here, another patient reported recently with a phenotype of juvenile idiopathic arthritis and ITP. And here you can see diffuse tenosynovitis of the hands and of the wrists. So the first step was to demonstrate the hyperactivation of the JAK pathway. And you can see here that upon stimulation by interferon gamma in BOBV cells and primary cell monocyte, there was an hyper response to the stimulation by interferon gamma in patients compared to controls. In another patient, it was also demonstrated that there was an hyper response to interferon type 1, here interferon beta, and you can see an increase of the phosphorylation of STAT1. And here by RNA-seq, you can see an increase of the expression of the ISGs, meaning the genes regulated by the type 1 interferon. And we also showed here with IL-2 an hyper response to the IL-2 with an hyperphosphorylation of STAT5. And it's not showed here, but there was also an hyper response to the IL-4 with an hyperphosphorylation of STAT6. In terms of impact on immune cells, we showed that there was the proliferation upon TCR stimulation here by anti-CD3 was comparable to the controls. But when we stimulated the T cell with IL-2, we showed an hyper proliferation of the T cells in response to IL-2, what was quite concordant with the data of Western blot showing hyperphosphorylation of STAT5. Giving the main manifestation of autoimmunity, we looked at the regulatory T cell compartment, and we show that the total number of Treg was decreased in patients. The expression of some key markers of the regulatory T cells, such as FOXP3, Helios, and CD25, were also decreased in patients compared to controls. And the function of the Treg, meaning the ability to inhibit the proliferation of T cells, while also slightly decreased here in the patient in blue compared to the controls, showing that there was mildly but still deficiency in the function of the regulatory T cells. Next, giving the hyperactivation of the JAK pathway, we looked in vitro first the effect of the JAK inhibitors. So we first tried the ruxolitinib, but JAK1, JAK2 inhibitors. And what you can see here, that when we pre-incubated the cells with ruxolitinib, we were able to completely abolish the hyperphosphorylation of STAT1 here in response to interferon gamma, and here to the hyperphosphorylation of STAT5 in response to IL-2, here with ruxolitinib. We show as well that the proliferation of T cells in response to IL-2 was completely blocked by the ruxolitinib, rather than the proliferation upon stimulation of the TCR was conserved when we incubated the cells, the T cells with the ruxolitinib. Then we looked ex vivo in a patient with a lupus treated by baricitinib, and you can see here before the treatment by baricitinib, but there is this excess of phosphorylation upon interferon gamma stimulation in comparison with the control. And when the patient was treated by 2 dosage of baricitinib, here 2 milligram and here 4 milligram, we can see a dose effect with a decrease of the phosphorylation of STAT1, what was under 4 milligram of baricitinib, comparable to the control. Finally, if we come back to the first cases, here the patient of the case 1 with the CVID phenotype, the skin rash, the skin eruption, and the alopecia here before treatment. And here the result 6 months after baricitinib, 2 milligram, then 4 milligram per day. You can see that the alopecia was completely cured. Here the alopecia was completely cured, and a clear improvement of the granulomatosis. And the safety and the tolerance of the treatment was very good. Here in the second case, as I told you, the patient was completely dependent to G-CSF, romiplastin, and IVIG every 3 weeks. And when we started the ruxolitinib, we could progressively decrease the treatment. And right now, he's only under ruxolitinib at the dosage of 0.9 milligram per kilo, and he could completely stop the G-CSF, the romiplastin, and the IVIG for the treatment of the ITP with a very good number of platelets. And as well, again, the treatment was very well tolerated. There is other cases for which the treatment was started. Here, a patient with psoriasis. So here, before treatment, the clinician started tofacitinib when the SOX1 mutation was identified, and he thought that the response was not complete, only a partial response. So he decided to switch the tofacitinib for the baricitinib. And here you can see after 6 months of baricitinib, but the patient is in complete remission. And finally, just recently, another patient, as I told you before, with a severe juvenile arthritis was treated by tofacitinib with a very good response, both on the rheumatological manifestations and on an ITP. So, in conclusion, SOX1 haploinsufficiency is a new primary immunodeficiency with a broad spectrum of clinical manifestation, mainly autoimmunity, but still also lymphoproliferation and susceptibility to infection. The physiopathology is a loss of an intracellular checkpoint inhibitor, and probably that the broad spectrum of clinical manifestation are due to the broad spectrum of the cytokines involved in the physiopathogeny of the disease. This loss of the immune checkpoint leads to cytokine hypersensitivity and the JAK pathway hyperactivation in the immune cells, and at least a part of the pathogeny is due to effector T cell activation with hyperproliferation and probably regulatory T cell defect. As I told you, the penetrance is incomplete with around 60% of penetrance, and this incomplete penetrance is quite frequently observed in PIDs caused by haploinsufficiency, such as CTLA-4, ICAROS, or FAT deficiency, suggesting that there is other factors involved, so maybe infectious triggers or other genetic factors. This immune deficiency showed that the molecules involved in the JAK pathway can be mutated with a gain of function, but also the regulatory molecules can be mutated with a loss of function, and at the end it leads to an hyperactivation of the JAK pathway, and it showed that these regulatory molecules are very important in the immune homeostasis in humans, and that these 8 molecules are non-redundant. And it shows again that we can treat this patient with targeted therapy and JAK inhibitors with all the questions that are asked before with the tolerance, the dosage, the pharmacokinetic, and so on. And so we started with Stephan L, an ESID registry, a level 3 registry, and the questions are to evaluate the penetrance, to evaluate as well the clinical spectrum, the laboratory biomarker, the risk of malignancy. As I told you, one patient developed an Hodgkin lymphoma, and evaluate also the response to therapy, especially to JAK inhibitors. And so far, we have identified around 50 patients that have been already included or are for whose the functional validation are ongoing. Don't hesitate to contact me or Stephan L if you have possible cases. Thank you for your attention.
Yes, thank you, Jerome. Excellent overview about this new disease. And I would like to pass on to Paul for another report. Please, Paul. You need to switch on your microphone.
Good point. Thank you. Thank you very much. My name is Paul. I currently work in the pediatric hematology and rheumatology unit at Necker. And today I'll discuss with you a case that is a patient who's currently hospitalized and for which we have severe side effects of JAK inhibitors. Okay, so to briefly summarize Clara's history, her father and uncle are actually sick of the same disease, and the father had severe alopecia, acne, several episodes of meningitis, growth retardation, and suffered from lung fibrosis and extremities abnormalities with necrosis. And unfortunately, he died at 29 years old following several weeks of hospitalization after necrotizing fasciitis. And the patient one here, a young 9-year-old patient, suffered from interstitial pulmonary lymphoplasmacytic disease with macrophagic alveolitis, who was treated for several years with steroids, Cellcept, and followed by rituximab, but unfortunately did not respond well. And so here is her CT scan in the 2013 when she was first seen in the unit, where we see a very severe lung affectation in January, who partially got better after antibiotic treatment because she was colonized with Haemophilus influenza, but clearly remained a very severe lung disease. And so a STING gain-of-function variant V155M was identified in 2014 in an exome sequencing. And following this discovery, she was treated with JAK inhibitors. So she was, as Bénédicte mentioned in her talk earlier today, she underwent several different JAK inhibitors, but JAK that are inhibitors are not directly specific to type 1 interferons. So Jakavi was introduced in June of 2014, which clearly changed the clinical course of her disease with a great improvement of inflammation and her lung capacity, and she gained normal lung function again. Unfortunately, Jakavi led to growth retardation. So 4 years later, she was changed for tufasitinib, who was slightly less efficient, and her lung disease got worse again, despite higher doses of tufasitinib. And so she was then changed to baricitinib in 2019, which led to a clear clinical improvement and normalization again of lung of pulmonary function. In addition, she has also undergone IVIG supplementation because of the JAK inhibitor treatments and to make sure she wouldn't have any severe viral infection. And of note, she developed cerebral idiopathic hypertension under Jakavi and is now treated by Diamox. And actually, this is still persistent because she still has edema in the eye, but is getting slightly better. So in terms of her disease for SAVI, she is actually much better. Unfortunately, she then developed several complications following inhibition of type 1 and type 2 interferons because of her JAK inhibitors. She, in September 22, she had an episode of hemoptysis and cough. And in addition, on her CT scan, this is a scan of 2 days ago, actually, but she had similar images in September of 2022. She had these images that were actually bilateral and showed, in addition, which we cannot see well here, a necrotizing ganglia in the that was in the mediastin. And so she underwent bronchoalveolar lavage, who identified Aspergillus fumigatus in addition to a non-virulent Mycobacterium avium. And so she was treated both by isavuconazole and tri-antibiotic by clarithromycin and ethambutol and rifabutin. Initially, she improved greatly, but then unfortunately, a few weeks ago, she got worse again with an additional pain in her chest, in addition to a worsening of respiratory function. And on the CT scan you see here, the lesions at the lung are actually getting worse again. And so she is again hospitalized. We're discussing more aggressive treatments in this patient. So overall, we describe here a 13-year-old patient with SAVI who initially got clearly much better under JAK inhibitors and for several years, who unfortunately had pulmonary infection with aspergillosis and low virulence Mycobacterium by Mycobacterium avium. This is difficult to treat because especially for Mycobacteria, we were blocking type 2 interferons, and she still has respiratory symptoms despite 3 months of well-conducted treatments. And so because of this worsening, we're now documenting in our unit if it's more the Mycobacterium or the aspergillosis who's getting worse. And in terms of discussion, we're obviously discussing more aggressive anti-infectious treatments, but also to stop this broad JAK inhibition and to maybe do a more specific type 1 interferon inhibition with anti-FNAR1 treatment with anifrolumab, which would ideally only block type 1 interferons. What we're scared of today is a potential flare-up at the initiation of anti-FNAR1 treatment and if we stop JAK inhibitors. With that, I'd like to thank you very much. Obviously, Bénédicte Neven and all my colleagues in the unit and all the physicians who take care of this young patient. Thank you very much.
Thanks, Paul, for the presentation of this challenging case. And I'm sure it will be another one of these cases that will stimulate discussion. So we move on to the final talk by Marie-Louise. And please don't forget to post your questions if you have any. Marie-Louise.
Okay, so good afternoon to everyone, and thank you very much for the invitation to participate to this webinar. So I work in the same unit as Paul and Bénédicte at Necker Hospital, and I'm also working on type 1 interferonopathy in Yannick's core lab at Imaging Institute. So I will try today to give you an overview of the side effect of JAK inhibitors. So as it has been introduced by Stephan and Bénédicte, when you think that you only block one signaling, you actually block many other signaling because there are many JAK involving many STAT, and there are almost 60 molecules, including cytokines, that transduce their signal through the JAK-STAT pathway. And so this pathway involved immune signaling, but also metabolic signaling, and this is important when you think of side effect. So one can expect a numerous side effect, and what is very important to consider in our monogenic patient is what has been already mentioned, is that you reach a pan-JAK inhibition when you use a high dose of any JAK inhibitor, either a JAK1 specific or JAK1 and 2 and a JAK or a JAK1 and 3. So as it is clear from the presentation today, the major side effects of this drug are infection, And you can expect this because when you inhibit JAK STAT, you can inhibit type 1 interferon, type 2, the IL-6 signaling, and also all the gamma-C family cytokine when you inhibit JAK3. What is quite interesting is regardless of the disease, including polyfactorial disease in adult setting or monogenic disease, regardless of the drug, the most frequent infection seen is the reactivation of herpes zoster. What is less frequent is bacterial or opportunistic infection. And in addition of the case that Paul just presented, I want to share you another story of a patient with COPA syndrome. She had COPA syndrome restricted to the lung with recurrent alveolar hemorrhage, no joint or renal involvement. We started her with ruxolitinib. She improved much, but still had disease flare, so we decided to switch her to baricitinib, and at that time we used very high dose of the drug, up to 12 milligrams per day for 50 kilograms, when we know that the dose in adult patients with polyfactorial disease is 2 milligrams per day. The last time we have seen her, we were quite happy because she was in clinical remission. She was even climbing in the mountain without any alveolar hemorrhage, but we were quite surprised to see on her CT scan bronchiectasis. And we were even more surprised when we performed a BAL and found an Neisseria meningitis, serotype Epsilon, what is quite rare in pneumonia, even in patients with immunosuppressive conditions. So we are in this patient and in all other patients where we do see opportunistic or really serious infection under JAK inhibitor, ruling out any other immunological defect. So when we mention this infection that can be a serious or opportunistic infection, what do we see with JAK inhibitors? We are quite concerned in our unit because we have seen both Mycobacterium avium and Aspergillosis. As Paul mentioned, we have seen this pneumonia with Neisseria, but we have also seen meningitis, septicemia in patients with Aicardi-Gouttières syndrome. What is can be quite concerning too is the Becker nephropathy, with a patient who died in the state, and other infections such as toxoplasmosis are also reported. I would like also to mention this case of GC virus infection in an adult patient treated with ruxolitinib. Now, I would like to give you, let's say, clinical, practical things to do before starting JAK inhibition regarding the infectious side effect. Of course, this has to be adapted to each condition and each history for each patient. So what is mandatory is to do tuberculosis screening, virus screening, and we highlight here that BK viremia should be screen before starting treatment. Vaccination should be updated, and regarding varicella, the status should be known before starting the drug, and the patient should be vaccinated if it's his or her immune status allows such thing. Otherwise, immunoprophylaxis should be started after any varicella contagion. Now I would like to move to other side effects and give you some key points, trying to do such a catalog. So cytopenia are seen, not so many in our patient, and this is explained through inhibition of JAK2 that transduce EPO and TPO signaling. It is important to consider the JAK3 inhibition when you use tofacitinib, since this inhibits T cell dependent function. Regarding lipid and cardiovascular disease, this is not very much seen in children. However, it is important in patients with autoimmunity to screen for antiphospholipid antibodies, because this could be important to be taken into consideration with the risk of thromboembolism under JAK inhibitors. Finally, regarding the cancer, because we all have this in mind when we are treating our children, the data from the post-marketing study for tofacitinib in adult patient is not so conclusive, and one can say that they are adult patients. However, we don't have so far long-term data in children, and especially if we think in our patient with monogenic disease that can be treated for years and years, this is still a remaining question. With a special focus in children, as already mentioned in this webinar, we did observe weight gain through JAK2 inhibition, and this is explained because you inhibit leptin signaling. And we were at the beginning, we thought that inhibiting the inflammation seen in patients would prevent growth failure. However, now we do believe that despite controlling inflammation in patients, the inhibition of the growth hormone signaling through JAK2 inhibition is a problem, and we do see in some patients growth failure despite controlling the systemic inflammation. I would like also to mention in this talk the role of interferon and JAK-STAT pathway in bone metabolism, because this is quite interesting. This pathway has a homeostatic role in bone, on both sides, on bone formation and bone resorption. And there is this paper published 2 years ago in a mouse model where the author showed that JAK inhibition increased bone mass in steady state conditions. So I remember this is happening in mice, and that inhibiting the JAK lead to stimulation of osteoblast function. So this is something to keep in mind when you use JAK inhibitors. I want now to highlight a potential severe side effect, the withdrawal syndrome that has been mentioned in this webinar in the context of the JAK being used as a bridge to a graft. So this is a life-threatening condition that is presenting as an acute relapse of the disease, but it also can mimic sepsis. It can happen, this is quite interestingly, just after or even 3 weeks after the drug cessation. It has mainly been described with ruxolitinib in adult patients with myelofibrosis, but also we have experienced this in several patients with monogenic type 1 intensopathies. It has been reported in adult patients under baricitinib, but with a much milder phenotype. And quite amazingly, it has also been described in dogs treated with a first-generation JAK inhibitor. And this phenotype in the dogs led some researcher to demonstrate the withdrawal syndrome in an allergic contact dermatitis mouse model. So here in dark, you've got the mouse treated with the vehicle. Here in gray, you have the mice with contact dermatitis treated with the JAK1 inhibitor. And when the drug is stopped brutally, you see that the mice that were under JAK inhibitor have a much higher phenotype, presenting as scratching than the mice treated with vehicle. And it is mimicking exactly what was seen in the dog, not quite interesting for us, but what we do see in the patient, where they are much have a much more worse presentation in the disease during the withdrawal syndrome. There is probably a differential mechanism of JAK1/2 inhibitors that explain that we do not see the same withdrawal syndrome depending on the drug. It is now shown that ruxolitinib block dephosphorylation and ubiquitin degradation of JAK1 and JAK2. So when you use this drug, you have to imagine that you have a lot of this kinase accumulating, and when you stop the drug, they are ready to trigger the pathway, whereas baricitinib has another action mode and prevents phosphorylation of the kinase. And this is probably why a middle phenotype has been described in withdrawal syndrome, implying baricitinib. So the take-home message for this life-threatening condition is to be considered in any case. The careful tapering when the JAK1 is interrupted is mandatory, and they may have the need to use steroids. And this, of course, depends on the underlying condition, the JAK1 use, and the dosage. Another really rare side effect, but that can be life-threatening is the pulmonary hypertension that has been described in adult patients treated with ruxolitinib. It is also described as a primary feature in monogenic type 1 interferonopathies. So this has to be screened before starting JAK inhibitors in monogenic interferonopathies. And this is consistent with the pulmonary hypertension seen in patients treated with interferon. So to conclude this part on side effects, so they are dominated, they are mainly including infection with the herpes zoster, but we're quite concerned that this severe opportunistic or bacterian infection that we see in our patients. These are the other side effects that we discussed today. And of course, the remaining question is the long-term effect in children, considering the cancer risk, but also the reproduction that could be perturbed by this drug, even if there is no data in the literature. And I thank you for your attention.
All right, thanks a lot, Marie-Louise, for pointing out and summarizing these side effects. So I think we have a quite complete picture now about this this drug and its use in this group of diseases. And there are many questions that have come up. I would like to start with a topic that is asked for discussion in many of these comments. And this is how to deal with infectious diseases and infectious complications. And I think we have seen that. I think we should split it in two, because the first question is, if a patient already has a persistent virus or a persistent infection, and people were asking about BK virus, about herpes virus reactivations, about chronic enterovirus adenovirus, would you start, nevertheless, knowing the benefits, ruxolitinib or a JAK inhibitor in such patients? That I don't know who wants to start here. Maybe Bénédicte.
Thank you. There are several questions behind your question. Of course, we are concerned by the BK virus because it was raised by Rafaela Goldman-Mansky in the context of interferonopathies. I wouldn't be too scared with the virus in the urine because it's quite frequent. I would be much more worried with the BK in the blood, because we know that if the blood level is high, the risk of nephropathy increase. So personally, I would be scared of starting JAK inhibitors in a patient with BK in the blood.
Yeah.
Regarding adenovirus EBV, I have less concern because it hasn't been shown in patients under JAK inhibitors, or at least severe infection were not really reported. CMV, I don't know. We haven't had any cases with CMV reactivation under JAK inhibitors. Of course, it's one of the viruses we monitor regularly under treatment. Probably if I have a positive PCR, I would decrease or repeat the PCR and monitor the level in the blood.
Right. Thanks a lot, Bénédicte. I think we should then look at the second side of this question, which is if infections or infectious complications come up during treatment. So this concerns viral reactivation, zoster, herpes simplex, EBV, CMV reactivation. Any comments on that? Maybe Carsten, you can continue.
Yeah, actually, I mean, I showed the slide for the retrospective study. I was a bit surprised that this really has not been a critical issue. I must say, however, we probably have also blind spots here in the study, because I mean, this is not a study protocol that was prospectively run and everyone was doing the same procedure. We were just observing what people are doing. So at least one could say that there have not been clinically critical infections picking up. Interestingly, I think most people do screen quite regularly EBV and CMV, so not so frequent BK in the blood. But at least it didn't give us a signal that there were significant numbers of patients having problems. What concerns me a bit is, and Bénédicte pointed this out, that the clinical experience with these drugs sort of started 2015-16 in single case reports. The experience in the autoinflammatory conditions is a bit longer, and it feels there's more and more infectious coming up in these longer treated patients. And so maybe we have also not had the critical mass of patients, although we already investigated 70, and maybe they have not been observed too long, although there is relevant number of patients who have been on the drug for more than 2 years. So maybe, Marie-Louise, if I can hand this over to you, what is your feeling in this autoinflammatory patients where there is maybe even a bit longer experience with these drugs, and where maybe it's even more easier to distinguish what is an infectious complication, because not all of these patients do harbor infections. I mean, this is also something in the JAK-STAT patient which might be difficult to assess, because infection are obviously also they are part of their clinical problems.
And probably some of the patients with autoinflammatory disease are protected by the mutation, and maybe some patients with type 1 interferonopathy have a remaining interferon response that can in some way protect them from infection. But anyway, we did observe this ourselves in Necker with Bénédicte, but also in the literature, zoster reactivation in this patient. And also when we switched to baricitinib, we did observe much more infection, probably because the drugs are not working exactly the same, even if they are both JAK inhibitors, probably because we are using higher dose from the PK data published by the Rafaela group, and we have seen that using higher dose leads to much more complication, even if disease is put into remission. So even in patients with autoinflammatory disease, there is a concern about infection. As mentioned, Aicardi-Gouttières syndrome usually are not infected. The patient tell us they are the less sick in the family. They have a disabling disease, an horrible disease, but their siblings have all the flus, etc., but not the AGS patient. And using a high dose of baricitinib, we have seen pneumococcal meningitis in a patient who has already a neurological involvement. We have seen septicemia, osteomyelitis. I presented you the case of pneumonia with Neisseria in a COPA patient. Paul presented you cases of Aspergillosis, Mycobacterium in a SAVI patient. So there is really a concern about using these drugs in our, I would say, in all our group of disease, either more from the PID side or more from the autoinflammatory side. So we are really waiting for more targeted drugs. Maybe this will give us the solution for treating this patient.
Okay, thanks, Marie-Louise. Bénédicte, maybe a quick answer. BK virus in the blood above 10 to the 4 while on Ruxo. How do you go ahead practically? Stop,
No.
restart, just continue?
This is a very difficult question. Of course, it depends on the disease, the stability of the disease. I would certainly not stop abruptly because I would be scared of the withdrawal syndrome. I think I would probably decrease the dose and monitor the BK viremia. But I never recommend to stop abruptly the ruxolitinib, even with a herpes zoster infection. I'm very careful with the withdrawal syndrome.
Right. How about the use of prophylaxis, antiviral? Here's also someone mentioning antibiotic antifungal prophylaxis while on JAKinib. Probably an individual decision. Any comment on that from anyone?
It's always a balance between the long-term prophylaxis and the risk of resistance. So we usually don't give acyclovir or long-term acyclovir to this patient, but we are very careful and we are very strict with the family when they see any signs of herpes to alert the doctors and treat. But we usually don't give long-term prophylaxis because we are scared of resistance.
Yeah.
Maybe a little addition to this, just a general remark. I think what is really important, because we didn't touch on this so much today yet, is to consider the effects of elimination that can be affected by other co-medication, in particular fungal drugs. And so this is why if it's achievable in a STAT 1 patient, for example, would prefer not to have the patient in parallel on a drug also, in addition to what Bénédicte just said, risk of resistance. And this is also important if the patient is acutely admitted for some reason to another hospital or something. It's often not considered that these drugs may have significant interactions, and this certainly needs to be looked in carefully when there's added co-medications in these patients.
Mm-hmm. Final comment on this from Alexandra Freeman. JC, I have seen reactivation and it makes me anxious, but I don't know what to do when the rest is improving. I think it's one of the dilemmas that we have, because it's some of these patients really benefit very much from these drugs in their quality of life and the whole disease evolution. So nevertheless, JC is obviously a concern. Marie-Louise, you have mentioned a case. Any additional cases observed? Carsten, in your registry? No. Okay. No. Good. Another area of discussion is the evaluation of responses and also the adaptation of treatment, concerning maximal dosing, concerning also how long would you wait until you judge the efficacy of the drug during treatment? And anyone who wants to comment on that?
Carsten, maybe you have the data from the retrospective study regarding the timeline of answers, which was usually quite fast.
Also briefly comment on PK maybe.
Yeah, so I mean, when I would certainly give the drug time to act, but usually we do see quite quick response. I mean, it depends on the different clinical phenotype. Marco can maybe also comment on this in a minute. So I would certainly expect effects in the first 4 weeks. I wouldn't give up before 3 months. It also, of course, depends on how urgent you need to see a clinical response. That may trigger how fast you escalate treatment. In particular, in young children, I would do PK before claiming it a non-responder. We really seen, and of course, then the question is, what is the target level. I think that's not very well known, but I think you're certainly too low if you have no detectable drugs for most of the day, and that can occur if you dose ruxolitinib twice a day in a very young child. And Marie-Louise also pointed this out, that many of these patients really need tremendous doses if we correlate this to, let's say, adult GVHD doses or so. So it's really, I think it's very helpful to look into the PK effects, and we at the moment don't know what is the right dose, the right drug level. I think all of these questions are important and need to be addressed in prospective trials, hopefully eventually. But I think that would be something I would recommend certainly before giving up to look into what is actually ending up in the blood in these patients.
Okay. In addition to that, Marco?
Yes, I would like to point out maybe the example of the CMC, which was asked in the Q&A, particularly, as Carsten already mentioned. I mean, it really depends on the disease manifestation. However, on the CMC, we saw it was reported around 90% of the patients responded within the first 6 months of treatment, with the almost 50% between 1 and 3 months. So it really depends on the manifestation, but below 6 months is probably for the CMC a reaction or response to monitor.
Okay. Good. We have a few other side effects that were touched upon, and I just want to throw them in, and maybe there's a comment on those. So one is alveolar proteinosis connected to ruxo, also thromboembolic events, and then maybe a comment on the frequency of cytopenia.
I can comment on the proteinose alveolaris. We observed one case in a patient with GVH who was treated by ruxolitinib and who developed PAP under treatment. So it's a very rare side effect reported with JAKinib. So this need to be monitored, and we have to be careful. The more we use the drugs, the longer we treat the patient, the more side effects we will observe. Cytopenia, it's something that we don't really see in our patient, and thromboembolic complication, we haven't seen any cases neither. But we are careful, especially in patients with biologic markers of lupus, for example. Some STAT1 gain of function patient may have anti-nuclear antibodies or biologic markers that need to be closely monitored.
Mm-hmm. Thank you. There was a question on wound healing. Any issues with wound healing observed? I'm also not really aware. So I see shaking heads. And then 2 questions about long-term therapy. Is this a solution for life? Of course, this is an important question. I see some shaking heads. Yeah, difficult to answer. Maybe I think there will be improvements in drug design. I think JAKinibs are an area of intense research, also including drugs that target different molecules in the pathway. So I wouldn't give up hope that maybe one day there will be more specific drugs. But at the moment, I think we have to be all careful, and I don't think we have to forget that transplantation at the right time point can offer a definite cure. So, right. I think that was most of the questions. There are some more detailed questions, and we have a few minutes left, so I will just pick out a few. Failure to thrive in STAT1 and especially STAT3 gain of function persists even after HSCT. Anyone has experience in treating failure to thrive and growth in these patients? Growth hormone is not effective like in STAT5B. Other possible treatments. So growth failure before and after transplant in gain of function patients. Any particular advice on this?
I think this is very difficult. I mean, in this individual patient level, and our patient numbers are really too small to provide clear guidance. I mean, STAT3, it can be, of course, part of the disease itself. It could be related to disease or transplant-related issue of bowel disease. I think it's very, very difficult to address, and I think we lack really patient numbers for this specific problems to be clearly understood at the moment. I don't know, Benedict, do you any other thought on this?
No, I have no experience of such growth failure after bone marrow transplantation. We haven't transplanted so many, so I have no specific comment coming from my experience.
So why was a STAT1 loss of function on Ruxo? I can just briefly comment. This was a B allelic mutation also leading to a rubella virus vaccine in the brain. So consistent with loss of function, but actually in vitro gain of function with an increased signature. And I think this points to a problem that we start seeing more often in STAT3 and also STAT1. Gain of function, loss of function is not a very clear definition in all cases. And I think in some cases that appear loss of function but show hyperinflammatory phenotypes, it is worth considering to use the drug. And I think we will learn more about this in the future. Right. Okay, was the reason for HSCT in this cohort of patients on JAK inhibitors having refractory uncontrolled immune dysregulation or uncontrolled infection? I don't know, Carsten, if you can.
Marco, would you like to comment? I can certainly give an answer, but I think you've just evaluated. I mean, it's in the end, it's a combination. I think for those undergoing transplant, the majority has been, well, I mean, the indication has been 1/3 has been immune dysregulation, 1/3 infections, and another third has been a combination of both, really. So, and as also shown in the cartoon where we showed the multiple manifestation, if you look in each individual patient, they have so many different problems. Usually that these patients do not have one particular problem, but they have really multi-autoimmunity, and these were then difficult to manage patients, and so that was the decision to actually then go ahead with transplant. And I must say, I mean, we were surprised to see in this 10 patient that the outcome seems to be very good, related to the also very few cases reported in literature initially, where there were reported high rates of rejection and hyperinflammation after transplantation. But overall, 10 patient also here is a small cohort, and there is an ongoing inborn error working study led by Katharina Schütz and others, who will look more deeply into the STAT1 transplant outcome. And I think this is really important that we look into this further, because I assume really lifelong JAK inhibitor treatment is also not an ideal option unless we have better substances in the future.
Okay, thank you. That was exciting. Thanks for beautiful talks, stimulating discussion, also the contribution of the audience. Thanks for staying with us until the end, and I hope that you will not be too long to keep up with your work before you go home. Thanks for joining us, and enjoy the evening.
Bye-bye.
Thank you. Bye.
Thank you very much, everyone.
Bye.
Thank you.
Bye.
Bye-bye.
Thank you.